Hello again for another season from Brain Talk. And this time we'll talk about the Pterion approach, the first season. The Pterion approach is the most known approach in the neurosurgery, most surgical approach in neurosurgery. Needs the Pterion approach. And the name of the Pterion approach is coming from the Greek word means wing, and the Pterion is the confluence of frontal and temporal and parietal and lesser wing of the sphenoid bone. The shape of this confluence on either sides of the medial fossa is like a butterfly wings. And sometimes this approach is named like a surgical approach because surgery Mr. Ghazi surgery was the pointer of this approach, and he developed a new technique for dissection of the Pterion approach or lateral fissure or Steven Fisher approach. So the starting with positioning of the patient. The patient is on supine position and head is fixed by Mayfield head holder. And actually, there's 2 points here. Don't put the nails on timber bone because it's very fragile and can be fractured. And also don't put the nails on the muscles because it can slip out during the operation. And also we rotate the head to the with the affected side, and it's best to take the position of the hip depression and lower limbs and trunk elevation. That means here is the trunk elevation, here is the lower limb elevation, and here's the depression of the hip. That's make a good instability stability for the patient fixation, and also a viewed prolonged nerve the neck traction. So the angle of rotation is actually depending on where is the specific lesion, and the general rule of the craniotomy is always not always from the non-dominant side, because sometimes some lesions can extend to the other side, and we're starting our craniotomy from the other side. And here also another very important nuances about positioning is put a latex coaching under the shoulder. So you raise the shoulder. This means neck, traction or neck, compression of the jugular vein to may less compression on the jugular vein, and this make the ICP lower and can also facilitate the venous return to the heart. So the head, as we said, rotates in different direction depending on the lesion, and also the zygomatic process should be at the highest point. And we also elevate the head raised above the heart with 15 degrees, because also that makes a good flow for jugular vein. So as we see here in this picture, this is a patient here, and we fix the patient with these screws in the superior temporal line, not on the temporal side bone, not on the muscle, temporalis muscle or any muscle. And also, we're starting from the non-dominant side almost in all of operation of the midline. And here also the tilting the head back, that's make the zygomatic process at the high point, and also brings the frontal lobe, makes using the gravity, they make frontal lobe the drop naturally. That's make less using the spatula or retraction during the operation, and this make also the brain to relax and not to injure during operation. So here it is skull-based aneurysm for direction. We have here the basilar apex here. We have also the communicating artery aneurysm and also the carotid, bifurcation. This is, the angle of, rotation of the head is 20 to 35. Whereas in, the Sylvian fissure lesions like middle cerebral artery aneurysm or hemangioma, we rotate the head 45-degree. Whereas in the midline, like anterior communicating artery or like cerebellar lesions like meningioma or like microadenoma, we rotate the head about 60-degree. So flap design for this patient, we must be careful to the aberrance of the flap design. So the angle between the two ends of the flap and the supraorbital lateral wall should be more than 150-degree, and flap starting from 1 to 1.5 centimeter in front of the tragus above the zygomatic arch and bends upward and gradually forward to the hairline and the midline. As we see here in this picture, starting if near the tragus is like 1 to 1.5, starting gradually upward, and that bending to the sometimes the ipsilateral orbital or to other side in some cases. So here, as we see, if we draw a line from here, from the first in the first of this incision, and starting also drawing a line from here also, where with these lines, when they dissect together, they make like 100 more than 120-degree. That's make a good supplying for the flap, blood supply for the flap. So from here, frontal and temporal regions, soft tissue anatomy. In the Pterion approach, we have frontal area and temporal area. The frontal area is consisting of skin gallia, aponeurosis layer, and Pterion layer. Whereas in the temporal area, we have like skin, superficial, temporal facial layer, and superficial temporal facial layer and deep temporal facial layer. Actually, no, we have here temporal facial layer is called the deep layer, and it's divided to superficial and deep temporal deep layer also. So here, starting interfacial manipulation, and the interfacial manipulation is the operation process of the skin flap separation from the superficial layer of the temporal muscle fascia and the fat bed between the deep layer of the temporal muscle fascia, so that maximum area of exposure and minimum brain traction. Here is almost our goal of this operation. So the frontal area, the skin and gallia apneurotica are connected by a dense tissue. Where is the skin gallia, skin and gallia layer and the Pterion are connected by a loose connective tissue, and this is here. Let's make a clear natural space for dissection for neurosurgery. Peristyle layer of the frontal part intercontinuous at the superior temporal line, and the superficial layer of the temporalis muscle fascia. Here, as you see here in this picture, this is the interfacial section, and here is the superior temporal line, and here is the temporal fascia as actually deep temporal fascia. So we're starting dissection of the superior temporal fascia, superficial, from the deep at temporal fascia with the fat bed with the superficial temporal layer. That makes very safe for dissection and prevent injury to the facial nerve and also vascular structure there. Here is another picture. We have here is the Pterion. Here is the superior timber line. Here is the deep layer of the timber fascia, the superficial part. Fat pads in this area, we have 3 fat pads. The first pad, fat pad is located out on outside the superficial temporal fascia layer, is the branches of frontal temporal branch of facial nerve and superficial temporal artery, and its branches walk inside them. The second fat pad is takes shape between the superficial layer of the temporal fascia and deep of the temporal fascia. And the lastly is the between the fat pad is actually between the deep temporal fascia and anterior and inferior to the second layer of the fat pad. As we see here in this picture, a very beautiful picture from Japanese microneurosurgery anatomy. This is here is the frontal muscle. Here is the Pterion. Here is the deep temporal fascia. Here is also the deep temporal fascia. As you see, is divided to two parts. The first part is called superficial, and the other part is called deep. Deep temporal fascia. It's called DDTF and SDTF, and between them is called the fat pad here. So another picture also showing the exact location of the fat pad, and here also another beautiful picture for the fat pad, which there is a second fat pad, and here is number 1 is the third layer of fat pad, and another picture also for the fat pad. Here is number 2 is called second layer of fat pad, and number 4 here is the deep temporal fascia. So thank you so much for listening to this small or short lecture about the Pterion approach and exactly about the interfacial dissection for neurosurgery. And in the second lecture, we'll talk more clearly about the anatomy of the Pterion approach. Thank you so much.